Thank you, Steve, for all of that. And thanks to everybody for joining us today. We want to begin, Pamela and I, just by recognizing partners, some of whom are on the Zoom, community leadership board members from around Indiana who are contributing to a community valued, action-oriented study of the Healthy Indiana Plan that's going on right now. Also, I see some members of religious communities in Indianapolis who've opened their doors and hearts and imagination to our students. So thank you for being here. And then also community and organizational partners whose expertise and participation are really the substance of the reports, the brochures, videos about HIP that we're going to reference today. So thanks to everybody for being here. And we just want to begin by emphasizing that Pamela's and my collaboration intersects with many different projects and partners. We are one little node in a big web. And the examples of the work we're showing today could not have happened without the work of many leaders and experts. So we just want to thank people for joining us today. Also, two quick words about our title, A New HIP Public. HIP is the Healthy Indiana Plan. And the Healthy Indiana Plan is how Indiana expanded Medicaid in 2015. So it's the Medicaid program for working age adults who are not disabled in our state. Public. In our view, there is no one public. In democracies, what is public good is always contested by diverse publics. Publics are groups of people with different visions of what, how, and why we might collectively invest to benefit the people. So we're really about the variety of publics and what it takes to build a new HIP public. Health and healthcare are areas with enormous government funding, but this funding doesn't always serve people well. So that's a lot of what our interest is in terms of health equity. Moving forward. So our work is framed by an ideal of democracy, and I just want to introduce this briefly. So for us, democracy is not a political system. It's not using elections to decide who's in power. Though both are very important, democracy is a way of life. Democracy is a culture that aims to be fully inclusive and reflective of diversity, and also seeks to empower people's wisdom and agency. So this is how we approach the idea of democracy, and it's very much central to the research we're trying to do. Many visionaries inform this view of democracy. My favorites include Walt Whitman, Jane Addams, Martin Luther King Jr., but we've included a quote here from John Lewis that crystallizes the perennial charge and perennial challenge of democracy, right? So for him, democracy is an act. It's not a state, it's an act that aims at the beloved community. And the rest of his quote indicates that standing in the way are powerful publics who are invested in the status quo, who don't want current advantages to change. So what act informs our scholarship? The act that we have sort of put front and center in the scholarship is trying to help inform and facilitate a new public that's invested in health and wellness for everybody. That's the act that drives the scholarship. HIP, the Healthy Indiana Plan, is central to that, but it's just a tool. And it's an imperfect tool, but it's used by many, many people. In fact, 1 in 10 people living in Indiana are on HIP. So it's a big, important support for 1 in 10 Hoosiers in our state. And we think we'd have a better society if more people knew about HIP, including how HIP helps support people in their health and wellness, but also how the rules can add harmful barriers.
Nice. Yeah, and so one of our key questions that we're specifically looking at in this talk today is how can research teams collaboratively engage with communities using participatory, inclusive, and visual approaches to co-produce moral language and shared goals that advance health equity. And so connecting back to democracy from a people-centered design perspective, it's about placing value on inclusivity and creating spaces that enable people to not only work collaboratively, but also share their wisdom and expertise to solve challenges in their lives. And so we pay careful attention to who is in the room, both in person and virtually, and take great care in understanding how the room is operating and how best to engage people. And so these values are carried throughout both process and practice. But most importantly, what is produced together, this co-production of outcomes is paramount. And it is not possible to co-produce these products and these things, even that we're mentioning today, without the inclusion and expertise of the communities that we work with.
So that little prefix co in the word co-production. So much depends on the little prefix co, to paraphrase William Carlos Williams. And by that, we mean that there's so much relationship building and logistical preparation that goes into creating these inclusive spaces. But more importantly, it's hard to convey in words the relational power, the cultural intelligence, and the transformative potential that can be generated working in communities. So this slide is an example of a 2019 study, which was a community-based participatory study of the Healthy Indiana Plan. The key leaders in the community on this were First Baptist Church North Indianapolis and Shepherd Community Center. And this happened back in 2019. This slide attempts to give a snapshot of how participatory, inclusive, and visual approaches can channel community expertise. And one of the things that is important to us about thinking about health is that so much of people's health and the health inequities in our society depend upon how people are connected to social supports or disconnected from social supports. We're really struck by the importance of connection to health or disconnection from health. And it's been really amazing to talk to people about their lives and their life journeys. It's humbling to hear what people share about their health journeys. And it's amazing what people have learned on those health journeys. So on this slide is an attempt to map out the journey that people shared with us. HIP is complicated. It's a very complicated process, but you can break it down into efforts to get HIP, to connect to an insurer, to use HIP, and to keep HIP. So this visual map was used to sort of channel these participatory focus groups where people talked about what helped them stay connected or what hindered them and kept them disconnected. And we gathered that one of the key lessons that came out of these sessions is about what's called the power account. The power account is central to HIP, and the acronym POWER stands for Personal Wellness and Responsibility. And the thought is give people incentives to take active steps to promote their wellness. And one of those is people have to make monthly premium payments into the power account, okay? So if you do this, you get full benefits and you don't have co-payments when you go to the doctor or go to the pharmacy. But if you don't make these premium payments, you drop down to basic, your benefits are reduced, and you have co-payments every time you seek services. Or if you're above the poverty level, you actually lose your coverage. So that's how HIP is set up. A central finding in this 2019 study was this: HIP's personal responsibility requirements are obstacles to people's using the benefits to support their wellness. The power combination isn't working very well. All right. Some of you may know that last month, a federal district court ruled that power account contributions inhibit people's ability to access care. This has been a sea change, and we'll come back to this in a second. But I want to emphasize that we see this ruling as the result of a tremendous amount of work by many, many people. And the ruling is not the end of the story. Okay, so this is a little bit about HIP. I'm going to move forward and talk about sort of the Bantz Community Fellowship that Stephen referenced in the opening. So in 2020, we tried to act on this broader community-based study in 2019 and applied for the Bantz Community Fellowship. We were very gratified to get it. And there were two streams in this. One was trying to go to local religious communities to ask them, how do they visualize health and wellness? We wanted to hear people talk about what health and wellness meant to them. And then we also tried to work with students and community partners to develop resources that would help people navigate HIP. So those were the two streams. This was very much a community engaged project. We've engaged 85 partners from 18 organizations, very collaborative. 80 students have been involved in this project, right? So much depends upon the word co, just to emphasize that again. All right, so that's what we're trying to do here. And I want to just say something about kind of the general approach that we think is really important here, which is communities are the experts. Communities are the experts. But importantly, what we're trying to do through this visualization process and these community sessions is to invite people to share their implicit knowledge. So much is taken for granted. So much is below the surface. And the things that are most important to us are so deeply held, we don't even talk about them. How do you invite that into the open? That's really the question that we're working on. And people, everybody engages in ethical, cultural, and societal reflection. What do people think about their society? And importantly, how can you invite people to imagine a different society? That's really the center of what we were trying to do in this project and these two streams of work. So this is the these are some examples of some of the posters that students co-designed, Heron students working with Pamela and religious studies students working with me, based on engaging with 8 religious communities listed to the left there. And we did participatory interviews with them. We did share back sessions with them. We offered these posters in draft form, asked people to comment on them. So there's very much an iterative process of trying to draw out this implicit knowledge and visualize how people understand health and wellness. Okay, so this gives you a sense of some of the 8 posters that came out of this, the overall design. You see students working together in these sessions, ideating and visualizing together. There's a nice image of students at Masjid Al-Mu'minin, one of our partners, being welcome there. And so we really thank our partners for the tremendous welcome that they have given us. We just want to spotlight a couple aspects of these posters because so much of what comes out of this is moral language and imagination of a better society. So the big picture one comes from Indie Community Yoga. And these are some of their core values: harm reduction, community care. But one of the really interesting ones is eliminate paywalls between wellness and needs. Oftentimes, people who might have the greatest needs for wellness have the biggest barriers to paying for them. So they make all of their sessions free. How about that? The one below that comes from Indianapolis Hebrew Congregation. And the students chose this line as the tagline there: justice, justice, you shall pursue. And then over here is Crossroads African Methodist Episcopal Church. And we wanted to spotlight this one quote: communal responsibility is the heart of African American communities. And so this community does a lot of work on social determinants of health in their neighborhood and trying to make lives better, because ministry is every day. So this just gives you an example of some of the moral language and imagination of a better society that comes out of this work with local religious communities.
Mm-hmm. Yes. And so for this other stream, so as David had mentioned, there were 2 streams in connection to it. So this one in particular, looking at a new HIP public or HIP allies, as we've, kind of evolved this project. In fall of 2020, it focused on working with our graduate students. So we had two visual communication design graduate students, Luis Garcia and Amrita Datta, and they facilitated through a design facilitation course that I taught in the graduate program, virtual participatory sessions with health insurers, with the Center for Interfaith Cooperation, and a learning community of historically Black congregations, with an overarching goal of being able to develop relevant and meaningful messaging for how to navigate and how to help other people navigate the Healthy Indiana Plan, or HIP. So our grad students had facilitated these sessions, and we were completely online, so we had to pivot during COVID. So you can see some images towards the bottom of different online tools that the students were using to help co-produce knowledge in and around thinking about the Healthy Indiana Plan. And part of when we talked earlier about democracy and the co-production and being able to create spaces, the students were able to utilize a lot of different tools, meeting our community members where they were, right? So they utilized a lot of different tools that were available in order to help elicit information and their expertise and their ideas. And so the grad students ran these sessions. And once they collected all of the information from those sessions, they developed conceptual prototypes, which were then shared with our VCD undergraduate students. So in the next slide, you'll see our undergraduate students beginning to work through conceptual prototypes that the graduate students had created based on all of the information that they collected in those sessions, and starting to visualize and think through what might public messaging around HIP look like, taking language, taking ideas, and taking insights from those community participatory design sessions. And again, we were completely virtual, so we were using different tools for them to start to think through what might that messaging need to include based on what they had heard from community members. And then the final products of this eventual a new HIP Public, HIP Allies stream ended up being a suite of not only brochures, but also it included some slide decks and some how-to videos, which have been edited and reviewed and designed not only by a team of students, but also involving faculty and engaging with our community partners to help give feedback on the language, the content, the visual style. The brochures themselves are actually hosted now on a website with our IUI Center for TRIP partners, which you can access. But you can see specific points in these brochures that are shown on screen here that are starting to look at specific language that was shared. So when we talk about the overall approach and process that's carried out in our research, we're employing tenets of people-centered design and placing value of people being experts of their own experience. And so the input that was collected from these various opportunities to try and connect with our partners, you can see, for example, in the top one, there's a sentence that says relationship is power. Another phrase that came from them was a healthy community begins with healthy people. So really trying to incorporate our community members' thoughts and feelings and emotions and needs and what they wanted to be communicated in these pieces so that they could be engageable and relatable and accessible. So in thinking about connecting overall with people, in David and I's work, we also really aspire to be enlightened and transformed by community wisdom and cultural intelligence so that public messages, how-to guides, community posters are meaningful and reciprocal and valid for our community members and our partners.
Yeah, that language of being meaningful, reciprocal, and valid is very important. And again, it kind of reflects all of the wisdom and contributions that people have shared with us. Mm-hmm. So we're pivoting to the now. When we agreed and planned this July Trip Scholars conversation, a primary goal was sharing the brochures to sort of help empower people to navigate HIP as the rules came back into full force. And importantly, July 1st was supposed to be the day that cost sharing returned to the HIP program. And in April 2020, when the pandemic started, Indiana moved to keep everybody enrolled because Congress asked people to do this and gave more money to do it. But Indiana also took the unusual step of suspending monthly premiums and co-payments to try to help people navigate healthcare. The rules to prove your eligibility came back in April 2023, and the cost sharing was supposed to return this July. So again, we've sort of been sitting on these brochures because cost sharing has been suspended and people didn't need to navigate plus versus basic. But we were going to release them and ask you all to help us. But importantly, on July 27th, the U.S. District Court for the District of Columbia issued an opinion in Rose versus Becerra that challenged federal approval of elements of Indiana's Healthy Indiana Plan, and that includes power account contributions. In addition, Indiana doesn't provide 3 months retroactive coverage, which is normally required under Medicaid to people who've just enrolled. And it also has a waiver that people don't people on Medicaid don't have to get non-emergency medical transportation, at least on some of the plans. But the judge ruled against these 3 provisions and basically sent it back to the Centers for Medicaid and Medicare and Medicaid Services to say, you need to re-review this request by Indiana to have these provisions that are different than normal Medicaid. Okay. So this is really important, just to set the context. Before COVID, there were a little more than 400,000 people on HIP. In April 2023, after 3 years of rule changes, that number had doubled to over 800,000 people. When the rules came back, some of those people were no longer eligible because they were over income, and people had to start reapplying. This April, there were still 700,000 people enrolled. So 700,000 is a lot higher than the 400,000 that were there when cost sharing was in place. Our concern was cost sharing comes back, what happens to this much larger number of people who, many of whom don't know anything about monthly premium payments, don't know anything about co-payments, don't know anything about plus versus basic, right? But the federal judge's ruling has actually put that on hold for HIP. Cost sharing is returning to the Children's Health Insurance Program. It's returning to MedWorks, but it's not returning to HIP. Okay. So one thing we just want to say is because of this federal ruling, the collective investment made in this one tool, brochures, as a means for policy change and public good, has been superseded by a dramatic change in the policy landscape and legal landscape right now. But it's important to say that this ruling doesn't take away the need to communicate what's happening in HIP for people who are on HIP. And the ruling doesn't take away the need to say there needs to be greater awareness. Rulings can be overturned. Legislation can displace a ruling, right? Building a public is not based on a legal ruling. It's based on the efforts of lots and lots of people working together, some of whom are on this call. And we just wanted to give a recognition of Community Leadership Board. This is related to a Robert Wood Johnson Foundation funded project that I'm one of the co-PIs on with Dr. Elaine Hernandez and Dr. Ivan Douglas Hicks. And working around the state are these Community Leadership Board members helping to inform and learn about people's experiences on HIP when the rules change and as the rules are coming back into play, with the goal of having some policy change and recommendations coming out of that. So we thank those of you who are on the call for joining us today. And I wanted to just open it up by inviting, I think Rachel Maxey is here, one of our partners, and maybe Rachel could share a little bit about her, the ways that MDWise has worked to help create the brochures and worked with some of our students.
Hello. Yes. Some ways that we've worked, definitely anytime David's reached out for advice or information about the HIP program and how MDWise is promoting and getting the word out. Definitely always tried to make myself available for those questions, and definitely was when the ruling came down, we were all set to send out all the invoices and all that good stuff, and kind of halted all that that Friday, which was very stressful for all of us at the MCEs because we had to hurry up and stop the trucks. Like literally our vendor was on their way to the post office to deliver the invoices. So that was very crazy time, but definitely our goal was or is to educate and encourage. We were encouraging individuals to participate in that power account. And one thing that we were doing and working towards was finding resources in the community for those individuals who may not be able to make the power account payments, getting connected to those grassroots organizations, churches, community organizations that would be able to assist with making those power account payments. Before COVID, there were a lot of different resources out there for individuals to get help with making those payments, such as the trustees' offices and things. And so during that time when we were ramping up, getting ready to, when cost share we were getting ready to start cost sharing again, that was one of the top messages that me and the other MCEs, we would jointly do different meetings and presentations to. We had just did a United Way presentation to the leadership of all the United Ways around the state, encouraging them to, hey, think about this is coming down. It may be, think about how you can assist in your when you're creating your fiscal budgets and things for the next year, and getting their minds on power accounts are coming back, and that's going to be another resource that's going to be needed. But since this ruling, we're kind of like at a standstill and waiting to see what happens. But again, just in the meantime, still educating about the HIP. It's still here, it's still available, and just navigating and helping those individuals get to those organizations that can help them sign up, such as Covering Kids and Families. They're a big partner with us that we work with, and especially when we're doing events, we make sure and try to get a rep there to educate about eligibility and how to enrolling in the process and all that good stuff. And then on our end, educating about, hey, who's MD-wise, what programs can we do for you or offer for you, and things like that. So very, very weird time we're in right now, but definitely still hitting that message out that, hey, we're still here. You can still, if you need that assistance, you could still get enrolled, and just educating and making sure they know we're here to help them and that you can get coverage.
Thank you, Rachel. I appreciate that. And I appreciate the work that you do in terms of outreach activities through MDWise to reach your members and keep your members informed and engaged. And I know it's a lot more than just sending communication messages out. It's working with people, it's building relationships. It's
being out there on the ground, being visible, so people can put a face to our organization, to Anthem, to MHS, so they know, okay, if they do have a question, they have that go-to person. Kind of, and also for the community organizations, David, I'll thank you so much for always reaching out whenever you have questions and things, and just keeping that communication open and being accessible for everyone so we can help solve the issue and get individuals help that they need.
Thank you. I'm also going to ask Dr. Hicks, who I see on the call, if he might share a little bit and contribute to the conversation, and then we can open it up more broadly.
Well, it's wonderful to see each of you on today, and thank you for this forum that allows us to talk a little bit about some of the challenges that we face and some of the victories that we can achieve. So I'm happy to have heard the dialogue that has gone forth, and certainly Dr. Craig, my co-investigator with our Robert Wood Johnson study, and Pam Napier, who keeps us on track and keeps us in line. We appreciate them for their work and for the diligence they have and the dedication they have to ensure that those that are without adequate health care or proportionate health care receive the assistance from not just wonderful navigators. It's good to see Sister Maxie on the line, but wonderful navigators and folk from MCEs. But there are people from every arena. There are people from every silo or sphere around that are really concerned to ensure that people that need health care receive health care. So we're very intentional about community valued research so that the Community Leadership Board that Dr. Craig has mentioned earlier today. One of the big things, even in allocating budget for our study, we ensured that a goodly amount of money went to the community, and our design in community valued research was to ensure that we have 5 different locations and we have co-leads and leads in those cities that are compensated because they are the experts, and we're gleaning data from them and input from them, and they've provided guidance and direction as we have made each step toward trying to determine for the study that we're working on the racial and structural barriers that prohibit proportionate health outcomes for Black and Brown people. But we're also not seeking to simply define probably something we already know, which is that health care is worse when you're poor and when you have a particular complexion. But the opportunity for us is to not just identify those things that are structural and racial barriers, but to then look for remediations, to look for solutions to problems. And we've been able to listen to experts around the entire state as we've done about 100 interviews with people that are HIP and HIP eligible. We've also engaged a community leadership board, some from the faith community, many from the health equity community in 5 cities, in Fort Wayne, in South Bend, in the region, Indianapolis and Bloomington. And we've had an opportunity to receive that input. And it's our hope that this is yet another step on today that allows us to be in greater relationship, because we know that in order for the impact of all of our work to mean something, we have to change laws, policies, procedures, regulations, and rules. That's the way it's documented. That's the way we know change has taken place. And so just wanted to say hello. Thank you to my colleagues. And thank you for all that you do in your respective walks of life that allow us to say that we are doing what we need to do in order to make healthcare accessible for everyone.
Well,
And
thank you
also,
all.
oh, sorry.
Go
Just
ahead.
a
Go ahead.
shameless plug. Tomorrow, actually, we'll have MD Wise is having our community health fair event. So we'll have navigators on site. IDOH is coming to do immunizations and a lot of community resources. So definitely, if you have clients, individuals you're working with that have questions, definitely send them our way. It's from 10 to 1 at our off of 2955 North Meridian Street location. So definitely that's an opportunity. If you have those individuals you're working with in the community, to send them our way. We'll have navigators on site to assist with questions and getting enrolled as well.
Well, thank you for sharing a lot of information and setting the stage for some good conversation. A couple of things to note is that there was one question in the chat to clarify that the date that you were talking about, David, was June 27th is when the announcement was made, not July 27th, which is tomorrow. So that just demonstrates how quickly all this is changing and how much confusion there must have been. I can only imagine being on the way to the mailbox and saying, halt, we got to change what we're doing again. And to help keep up to date, it was mentioned earlier that the information about the new HIP Public is available on the Center for TRIP's website, and Nuri put that in the chat if you want to take a look there and bookmark that for this ever-changing information. But let's open it up. What other questions, comments, discussion would folks like to have? We'd love to hear what you have to say or questions you have, etc., about this topic.
Well, I don't really have a question, but a comment, I guess, and a request. First of all, this was fantastic. My name is Wendy Miller. I'm from the School of Nursing. I'm the Associate Dean of Research there. I think there's so much opportunity for other schools like the School of Nursing to be part of this. And we have, if there's any way that our nursing students, they do community engaged clinical, if they're not already, I don't think they're already plugged into this. But if that could be something that we could orchestrate to have them, because we're really trying to get their focus also onto preventative health care instead of, excuse me, just acute care, and trying to show them how the social determinants of health really do. Sometimes people end up in the acute care system because they don't have access, and it's better for them to see this rather than us just talking about it. And I think there's some data we collect there too. So not really a question, but just sort of a a plug that we would love to be involved and help with this. This is incredible work.
I love that. Thank you so much, Wendy. We will, I just actually wrote down your name. We will be in contact with you. Absolutely. Because we're constantly, we're always looking for more opportunities, right? To bring
Absolutely.
people in and connect. And one of the other things that we're curious about too is, how do we share and disseminate this work, right? Through both academic and community channels. Like, how do we get the things to the people that need them? And so that's something where, putting the pieces together and getting them hosted on the website, like that's one avenue, but that was also something that we were curious if anybody had any thoughts about, how do we get the stuff out to people who need it?
Yeah, and
yeah.
we do rural health clinics, and a lot of our nurse practitioner graduates are working in very rural, underserved settings. And I don't know if they have this information or if they could somehow be partners. We get people who come to our rural health clinics who may get their cholesterol tested and their blood pressure screened, and then we may refer them to a PCP. But if you don't have a PCP because you don't have health insurance, that could be something there where we could use some of this information materials to help connect people who are coming to those rural health clinics. And we've also done some urban clinics in downtown Indianapolis that are church-based. So I think there's a lot of opportunity there for us to use what you're already doing to connect those folks to the information they need.
That's great. Thank you.
Wendy, I really love your question because it just demonstrates the power of the interdisciplinary approach and the that David was talking about people working together. And because just listening to this, I really admire how the partners have come together already to create this so that it is information that's very powerful and in words and in ways that make sense to those that need it. And now here's like the next level of how do we disseminate it in ways that make sense to get it to people that need it. So I'm so glad you asked that question. It's a really good demonstration of what we hope to see happen more and more of, and why we have these conversations to bring people together, to share what's going on, and to get out the information and to make things better, to take evidence and turn it into something useful. Other thoughts, comments?
I'll just add an idea or way to get the information out is to take it to where people already are. So making sure that information's in the healthcare centers, those different agencies that are community facing, that people come in for assistance or services, making sure that that information's with them. Networking, basically just getting in front of all those folks who provide some type of service and see individuals on a regular basis. That's what we try to do, is getting our information in the health center spaces, especially, or the ER, even thinking outside the box, going to a retail center. We've been working with Walmart a lot lately, so getting information there, or just thinking of places where people already are attending or going, and working with that agency or that organization or place to house that information there. So when they come in, that's the first thing they see.
Yeah, that's great, Rachel. Thank you. Ted, I don't know, Ted Grain, I don't know, were you starting to raise your hand? I saw you.
Sure. Hi, everyone. A shout out to Dr. Hicks and Brian and others that I know on the call. Thanks for doing this. I've been kind of following from afar this work, and I really salute you. I know it's been a long journey, and it's really, really cool to see not only the participatory with the community, all the efforts there, but then how it directly relates to legislation in the moment right now. So this is timely. So I have basically kind of two questions, but then a comment. In answer to kind of like how we should, I think you asked the question, Pamela, like how do we get this out there to people? One of the things that we've done at Eskenazi Health, so I'm the Vice President of Social Determinants of Health for the Eskenazi Health Foundation. And I also have a role on the hospital side as Director of Social Determinants of Health. And as part of that, we created this new role at Eskenazi called a community weaver. A community weaver is kind of a cross between a community health worker and a community engagement person. But the idea is that the role has an assigned territory, has a geography, and within that geography recognizes that there's really important community assets that we just need to be touching base with on a regular basis. And the role is meant to see the neighborhood as the patient. So it's really kind of a community health role, not individual patient role, although they do connect individual patients to resources as well. But the idea is that if you have a super connected individual that becomes the face for a specific area, that you can then really expedite sort of information sharing across the board, because it changes all the time. So we have to invest in the infrastructure for that. So that's just a thought. Could share more about that at some other point. And then two questions are, as you think about, and maybe it's just one question, as you think about, okay, this is real-time information. How do you get the information back to the people in the community, but also directly to legislature, the folks that are making decisions at the state house? Who is actually doing the work of both the policy as well as the liaisoning with the community?
I'm hearing that as a question. Who is actually doing the work of connecting with policymakers and doing
just like this is
liaison?
it's such great information, but then how do we take what was shared today and then take it all these other places? That's all. I think that's a constant challenge for me and for our work, is like you kind of know what to work on, but then how do you do it? So
I completely agree. I think one of the reasons for a community leadership board, is particularly in Dr. Hicks' vision of it, is to build that network of not just the members, but the people they know, right? So that the more there can be a kind of network across the state of people who are engaged and invested. But there still has to be that kind of relational communication and that ongoing, and it's hard to know how to find that kind of resource, right? That communication connection piece. Academia is particularly challenged in how slow we operate, but we're trying to be quicker too, right? So these are some of the barriers that go with that. And I see Susan Joe had her hand up.
Yeah, and before Susan makes a comment, welcome Susan, who's with Covering Kids and Families. It is about 10 till the hour, and we like to take a pause here and thank our speakers and our scholars for sharing this information, and their community partners who have made this so real. But we realize that some folks might need to take a break here to get ready for their next meetings for the afternoon. So we want to thank them for coming. Reminder, you're going to get a survey in your email afterwards. Please let us know what you thought. Come to the next sessions. Pay attention to all the things that are happening here at the IUI campus. And if you have questions and ideas, plus reach out to us. We see where there are opportunities to keep doing this work. But we're not going to end this conversation. For those that want to stay, we'll just stay on here for a while and continue as long as we can.